So, Dr. Raj, should we ask Dr. Bilal to give the lecture?
He's on. Dr. Rai, you're on mute right now. You have to unmute yourself.
Dr. Bilal, if you could get on with the lecture, because we have to be with the live case, otherwise we'll have to skip both the lectures.
Are you able to see my screen?
Yeah, it takes a little while to upload. And yes, we can see the slides, Dr. Bilal. That's great.
Okay, great. Okay, inshallah, let me start. Assalamu alaikum, everyone. Let me quickly start off by thanking everybody for having me today. So my job today is just to talk to you about the fundamentals of retrograde PCI, and I'll just try and go step by step. I don't have any disclosures to give. This is a familiar image to anybody who's done CTO PCI. This is the hybrid algorithm talking about the 4 different options to crossing CTOs. 2 of them are antegrade and 2 of them are retrograde. And I'm going to try and focus only on the retrograde approach today for you. So this is a image essentially that summarizes to you the different steps that are involved in the extensive planning that goes ahead of time. The technical aspect is one part of it, but there are about 9 different steps before we can actually successfully say we've crossed the lesion and you're on your way on to stenting, which is relatively the easier part once this is all done. And I think it's really important for the success of any procedure for you to have a very detailed, comprehensive assessment plan, understand your own skill sets, understand all the equipment that is necessary, and all the steps that are needed.
Dr. Bilal, if you go on slide share so we can see the full screen.
I am actually on slide share.
You have to
slide
press
show.
that.
Bilal, slide show so that we can see
where
the
screen is. You have to press that.
Yeah, I'm on that. Let me stop it again and let me try it one more time. Okay.
No, Bilal, slide show. It's at the bottom. Just click on the slide show.
Yeah. Bottom right is the screen. You have to press that for slideshow.
If I am on the slideshow,
okay, we can just carry on.
Okay, that's fine.
Yeah, well, let's carry on.
Yeah, I apologize. Something must have changed over here. Let me see one more time. Slideshow. Did that show up now? On the bottom right here?
It's not showing, but let's just carry on. We can make out. Yeah.
All right. Sounds good. All right. So we'll need a very specific toolkit, and I won't go into the details because there will be probably a separate talk about that. But just so you know that all the equipment is very specialized in CTO PCI, as you're all familiar. And I think once you get into the retrograde option, then you really have to have very specific wires and microcatheters. And it's important to understand what wire is used for what step. There are different wires that are used for a septal collateral versus a epicardial collateral. The techniques of wiring, surfing a septal wire versus actually crossing one. The use of guideliner or guidezilla to help you with support. The externalization wires are all specialty wires. And of course, with the higher incidence of coronary perforation in CTO PCI, very important, of course, to be able to manage that, not just for the septal perforations, but more importantly for the retrogrades, because when they bleed, they actually bleed from both sides, antegrade and retrograde, and therefore become more challenging to manage. Safety first, important to understand some limits here. It's ideal to keep the radiation exposure to less than 5 grays, minimize the contrast utilization, maintain an ACT of more than 350 for retrograde options because the amount of gear that goes into these guide catheters, despite an ACT of 270, 280, you can certainly develop a thrombus. And of course, being aware of the vascular complications from long femoral artery access is really important. The indication for CTO PCI for retrograde is essentially fundamentally 3. When you have a distal cap at the major bifurcation, if it's a true ostial occlusion, or if there's an ambiguous proximal cap with a long, more than 2 centimeter CTO, in the presence of good interventional collaterals is really the main indication for retrograde approach. The 3 options are going to be vein grafts, which are the best and the safest ones, septal perforators from the LAD to the PDA or vice versa, or of course the epicardial collaterals that can be from the RCA to the circumflex or vice versa. And in being aware of the risks of each of these and being prepared is really essential. So the key to success, plan. Spend at least 15 minutes studying your angiogram, discuss your approach with your team members, keep all the options, be flexible, and be willing to change between antegrade and retrograde approaches if one is not working. and the other should be attempted. And studying the angiogram, I think, is absolutely essential thing. When you look at an angiogram, kind of look and see where the collateral connects with from the donor to the recipient vessel, at what point, what is the length and distance between the point of reconnection and the distal cap, what angle are you approaching it from as well is very important. And there are ideal collaterals, which are obviously hard to find. The ideal one is that when it exits from the donor vessel at an obtuse angle of more than 90 degrees, is more clear, doesn't have much tortuosity, it looks more like a side branch, and the connection with the recipient vessel is also an obtuse angle. And all those things allow you to have a scoring system, which is summarized in the slide over here, where you look at the connection and the size, the entry from the donor vessel, the collateral tortuosity, and then the collateral relationship with the recipient artery, which give you a scoring mechanism, which will give you idea about how difficult it may be. So for instance, in this particular image, you can see here that this particular septal collateral from the LED is straight, it's large, has minimal tortuosity, has an obtuse angle from the beginning, from the LED and into the PDA, and this would be the ideal one versus the other options, A, C, or D, which are much more difficult to access given the angle of at which they connect with the vessel. So, of course, be aware of the retroflex septal branches, in which case some special wiring techniques are needed. You have to have a special bend around, a little larger bend, go past the septal branch, and as you come back, the wire should be able to kind of drop into the septal and then straighten out with your microcatheter and then being able to advance into the septal and then changing out this angled wire to a separate wire which has a different, much more straighter angle is the way to go. So let me go through some angiograms here and kind of go through what we're talking about here. So this is an example of a case that I did. This is a patient who has a calcified right coronary artery, not so much visible by angiography, but it's some level of proximal cap ambiguity. And there is a lot of distal disease here as well. You can see over here that the septal collateral here is really a nice approach here. However, the origin of the septal is a bit of a retroflex, which is why you see this little exaggerated angle over there, and then use of a turnpike LP microcatheter to help enter the septal branch, after which this wire was taken out, and either a scion wire or a SUA3 wire is used with a small 20, 30 degree angle, maybe at the most, to be able to enter and go through the septal branch. And septal surfing is really more of going quick in and out. If you need resistance to stop, you really can't wire a septal branch. You just have to keep trying different angles and different branches. And when it goes, it'll just float. And I always watch out for PVCs. I never assume that it's in where it needs to be. It needs to be confirmed with retrograde angiography to demonstrate before I ever move my microcatheter or a channel dilator through the septals into the collaterals. I always want to make sure that it's in the vessel. Once you are actually through the septals, and the next step would be to push the wire out as far as possible until it gets to the distal cap. And once it's at the distal cap, then advancing the microcatheter. And one of the techniques that's really helpful, especially as the vessels become more calcified, is that the microcatheter sometimes may not go depending on the angle at the base of the heart, or there might be a tight stenosis somewhere. The guide catheter backup may not be there. So using a guide liner and then using a trapping technique is extremely helpful. In this particular case, you can see here that I have a guide liner into the proximal RCA, and the microcatheter has reached up to the mid RCA. And then in order to enter the guide liner, I have a trapping balloon which has trapped my retrograde wire. And as you trap that wire in the guide cap, in the antegrade guide, and you tug on the wire outside the body, it really helps to push the turnpike LP all the way into the antegrade guide. And once it's there, then of course the next step is to be able to externalize the wire and then go over it and stent it. So this is the final result in comparing with the proximal pre-PCI angiogram. This was the final result. Now, using the saphenous vein graft as a retrograde channel is also essential skill set to know. This is an example of a patient who keeps having restenosis and comes repeatedly with ISR and non-STEMIs due to graft disease. So I'm going to try and open up this left main into the circumflex artery. It's a wide open graft. It's the safest one to use. But I know that my guide backup is going to be a problem. This is severely calcified. So I'm going to go in with guide liner utilizing that guideliner to put in my retrograde turnpike LP and wiring up to the distal cap with the Fielder XT. Once I get there and I advance my turnpike LP using the guideliner for support, then I can exchange my wire, make into a nice knuckle, and then really push the knuckle hard and letting it dissect it all the way through this densely calcified segment until it reaches the distal left main. In this particular case, because of the calcification in the proximal circumflex, I'm not able to advance my turnpike LP all the way into the aorta. So here I'm using a balloon in the left main over an antegrade wire to be able to trap my retrograde wire and advance my turnpike LP. And by doing so, I can come close enough to the left main with the turnpike, then we can then take a fresh wire like a Pilot 200 and then be able to retrograde access into the left main and into the guide catheter. And then once we have that large externalized wire with a rail, we can then go ahead and stent it. Whether you decide to close the vein graft or not really is a matter of choice. Most of the times, people tend to do that if there is a lot of competitive flow, because of the risk that your CTO PCI may not be successful eventually. I do want to touch briefly upon the epicardial collaterals, which are a whole different level of challenge. But really, it's all about anticipating challenges. This is a gentleman, 51-year-old, morbidly obese, who I had actually tried twice before with an antegrade approach. Severe, profound calcification that I had done rotablator here just to open up this area up, and the wire would every single time just keep going into the dissection plane, and I never really entered the distal lumen. So the third time around, because of class 3 to 4 angina, we actually went in with the retrograde approach. My only option was to access this very, very tortuous epicardial collateral from the proximal RCA that makes its really upward course all the way up and then comes down to connect with the right posterolateral branch. So here I have a turnpike LP catheter with a Fielder XT, and after some
Bilal bhai, the live case is kind of ready, so maybe last few minutes and
Sure. So nevertheless, just let me know whenever I have to stop, and I'll certainly do that. I was able to cross this. So crossing this with the distal, with a Fielder XT wire, going to the distal cap, running into a non-crossable distal cap meant that I had to use an antegrade dissection technique once again. And once I had the two wires overlap with each other, performing a reverse cart in the distal RCA, then using guideliner assisted retrograde wiring to advance the turnpike LP, and then subsequently being able to stent over the externalized wire and getting this result. This is about 6 years ago, and he has done extremely well. So again, please, I can stop anytime you want, and until you tell me, I'm just going to keep going, Sohail bhai. So this is an example of a patient who had a LAD and RCA CTO. The LAD was dependent upon this RV marginal branch, and I had a extraordinarily calcified proximal cap, which wouldn't allow me to do IVUS guided puncture. So my only option left was to actually utilize this very, very tortuous epicardial collateral from the circumflex artery, which, and I'm going to summarize to you about a 6-hour procedure here and just a few slides here. Just being able to wire this very tortuous circumflex. Again, knowing what wire, SUA wire for me works best in a situation like this. It's very soft and, very atraumatic, soft tip. And always, I don't trust where the wires are. I make an effort to try and memorize the vessels, the number of twists and turns, wait for the diastolic phase to advance your wire gently, take frequent tip injections to know the course of your direction of your wire. And then if you do it very slowly, very gently, here I was able to successfully cross the CTO segment here. As you can see here, the wire finally crossed the epicardial collaterals and entered the distal RCA, at which point I was able to then do a retrograde distal cap crossing, followed by, once the wire goes inside the guide into the aorta, I was able to trap it inside the guide catheter, advance my turnpike LP, and then be able to finish off the case by putting in a stent antegrade from the proximal distal RCA. So these are just some of the examples of CTO PCI. Do I have any more time, Sohail bhai, or am I done?
We are really short and they're waiting for us for the live case. So concluding
No
remark,
problem.
maybe?
My conclusion slide over here, essentially, as Dr. Lombardi just said, just needs a high level of commitment, a personal commitment to yourself that you're going to learn to do this, and it's a lifelong procedure. It's really difficult to be an expert in this matter, but it's just a matter of learning one step at a time and becoming really good at it, and just remaining really humble and having the right tools, keeping your team engaged, and asking for help from people who are your and other people who can guide you through this procedure, and just kind of review and debrief after every procedure, know what you did right, know what you did wrong, and just make yourself a better operator every single time. Thank you so much for your time.
Great. Sorry to rush you guys, but the cath lab in China is waiting. We have Dr. Wu with us, who's going to introduce us to the cath lab and the case there. So over to you, Dr. Wu. I hope you're online.